Good afternoon, everyone. Welcome to the Virtus Fertility Center Singapore's webinar, and thank you for spending your Saturday afternoon with us. My name is Pearl, your virtual MC for today. Now, before we start, just to let you know that I have muted all of you to keep the webinar conducive for everyone. Q&A will ensue at the end of the third presentation, so for any burning questions that you may have in between each presentation, feel free to submit them through the chat option, and our presenters will try their best later to answer your questions at about 3:35 p.m. But if you're shy, you may also drop the questions directly to the host, which is myself, and I will assist to raise it up later. Today, we have with us three highly experienced professionals who will be sharing useful information with all of you today. Without further ado, I shall invite our first presenter, who will be sharing with you on mind and body in IVF, lightening and empowering by Ms. Prue Jones, our fertility coach. Ms. Prue, please.
Good afternoon, everyone. Thank you for joining us. Thank you, Pearl, for the introduction. So my name's Prue, and I'm one of the fertility coaches and therapists at Virtus. I've been with Virtus for about 4 years now. And Virtus takes a really holistic approach to IVF. And I almost kind of like to view it as looking at it as 3 legs of a stool. We like to consider, first of all, your physical health. So we've got great doctors that work with us, then great science, and Dr. Liao is going to go through some of the stuff that they do at Virtus. And then the third leg of the stool is the mental health. And there's so much evidence now. The more relaxed we are, the better our bodies function. And the idea is that when you've got these 3 legs of the stool, that's when you can kind of sit back and let go a bit. And that's when IVF has got its best chances of working. So for our agenda this afternoon, I want to look at 3 things. First of all, what's happening to the mind in IVF? Then what key areas are impacted? And then how can we empower and lighten the journey for you? So let's kick off with what's happening to the mind in IVF? What's going on? This is a really powerful quote that I just want to read to you. The psychological distress associated with infertility is comparable to that associated with heart disease, cancer, or HIV, and fertility treatment patients often characterize infertility as the most upsetting experience in their lives. So it does have a huge impact. Having children, starting a family is massive. And what I've kind of done is I've pulled evidence from scientific papers around the world and our experience at Virtus over the years as to kind of what's typical, what's normal. So I wonder now, if you have a look at this question, the first one, what proportion of women coming for IVF fulfill criteria for a depressive and/or anxiety disorder? And the options there are 15, 20, and 30%. Okay, the answer is actually 30%. Look at that little cutie chewing his toes. And for men, do you think it's 5%, 10%, or 15%? It's actually 10%. And this is one of the things that is also interesting coming out from the research and from our discussions, is that people often think of IVF as the woman, the impact on the woman, whereas actually, the men are part of the journey as well. And what else do we see going on? Over 50% of people coming for IVF, understandably, have lost confidence in their fertility. But it's not just fertility, you've got work stress coming in, 45 to 55% with work stress and 45% anxiety. So there's a lot going on in our lives. And remember, we're juggling fertility and the desire to have a family with everything else that we're managing.
Sorry, Prue.
Yeah.
We can't see your slides. Are you able to share them with us?
Yeah, I have been. Hold on a second. I'm so sorry.
Right. It's all right.
So sorry.
Maybe you can try again.
Yeah.
Now I can share it over here.
Hold on. So where did I get to in any of that? Where were you with me?
I think maybe you can start from the first slide. I think we haven't seen
Right
it
from the
yet.
beginning.
Yes.
Okay. Okay. All right. Hold on a second. Because you guys dropped off my screen.
Okay, we can see it now.
Can you see now? Okay,
Yes.
good. Right, I'm so sorry about that, everyone. Right, so I was talking about Vertis's holistic approach and the three legs of the stool. Great science, great doctors, and the mental piece, right? And then I covered the agenda, the three things: what's happening to the mind, what key areas are impacted, and then how we can empower and enlighten your journey as you go along. And then I read this quote to you about the impact of IVF on our psychological state and how it's comparable with these serious conditions. Then I asked you these questions. What proportion of women coming for IVF fulfill criteria for a depressive or anxiety disorder? And it was 30%. And you didn't get to see that little cutie chewing her toes. And then for men, 5, 10, or 15. And the number was 10. Okay. And then also what we're seeing through the couples that we see coming into Vertis, and again, pooling research from around the world and couples dealing with infertility, is a 50% loss of confidence in fertility. And then these work stress figures of 45 to 55%, and then 45% with anxiety. Now, with these figures, the aim is to normalize, not to terrify you. And the statistics might sound scary, but what I want to say to you is if you feel any of these things, first of all, it's normal and you're not alone, okay? But the other thing that I want to emphasize is that everyone's journey is different. There's no right or wrong way of doing this. But if you do feel any of these things, you really are not alone. And that's why we're here. That's why Vertis believe in having a team of therapists trained in these areas so that we can really support you and help you throughout this journey. So what do we see in our sessions? What comes up and what does the research tell us globally? 3 key areas seem to be impacted. First of all, your relationship, okay? Secondly, this need to be in control. And then thirdly, our chit chat, busy minds and what they have to say about things. So I'd like to have a quick look at each of these in turn. First of all, relationships, okay? Now, any stressful life event can rock a relationship. And Gottman's couple therapist, which is one of 2 evidence-based couple therapy interventions, they've spent years studying couples. And it's actually quite frightening. They're a couple themselves, and they believe that within just 10 minutes of meeting a couple, they can predict with 90% accuracy whether a couple is going to get divorced or not. So I said to my husband, if they ever come to Singapore, not meeting them, don't want to know. But what they've discovered in all their research, and they've done, hundreds of papers on couples, is that when you get big life events, like trying for a baby, like the arrival of a new baby, 60% of couples have a reduction in marital satisfaction, and it doesn't come back. So what happens is, under the stresses of the storms that life throws at us, it almost like it rocks the foundations of the relationship. And the good news is, in all their studies, what they've found is they've found what works for that circle at the top, the ones that stand firm. And with their evidence and what they found, we can actually kind of get some ideas to help couples. And so with their research, what they did is they built this sound relationship house. These are the relationships that whatever life chucks at them, whatever storms throw, whatever changes come, these couples can stand firm, okay? Now, I'd love to spend hours going through all these layers, but we can't. We're going to focus on the trust and commitment on either side. And then the most important bit, I think, the foundation, the building of the love maps Okay, so what is a love map? Now, Gottman couple therapy believe that love maps are kind of almost like the part of the brain where you store information about the other. And love maps contain two bits of information. They contain all the information about the big events in your partner's life, and also they keep it up to date. That's the most important thing. And this is the thing, this is why maps is such a good analogy, because if you can map your partner's inner world, when you're under stress, you easily know how to help the other one. But if you don't keep your map up to date and the storms start coming and difficult things start happening, you can't help them. You can't get to them quick enough. And if you imagine a map of Singapore, I've been here 15 years now, 15 years ago versus now, you'd have a nightmare trying to get from A to B because so much has changed. You know, you've got condos coming up, you've got new MRTs going in, roads that were two-way and now one-way. And that's the same with our internal lives. And when we get married, we know each other's maps really, really well. We're in that loved up hormonal stage of, they actually call it luminescence, where we know so much about the other. But as our lives evolve, if we don't keep each other up to date, we can do this, move apart. So some questions that come from love maps. I wonder how up to date your love map is with your partner. And there's some great questions here. What was my most embarrassing moment? What was I wearing when we first met? What's my fondest unrealized dream? What's my favorite time of day for lovemaking? What was one of my best childhood experiences? Who's my least favorite relative? I think it's probably quite an easy one to answer for me anyway. But I wonder with these, if you sat down this evening and asked these with your partner, whether you'd know the answer. And I wonder whether the answer you gave might be the answer that your partner would give 5 years ago, 2 years ago. I wonder whether it would be the answer right now. And this is the really interesting thing, is friendship is really the key to passion as well. And 70% of your sexual, passionate satisfaction in a relationship is dependent on the quality of your friendship. So not only do we see couples during IVF have their emotional connection tested, but also sometimes their physical connection as well. And so love maps, knowing your partner's inner world, ensuring that you know how to help them, what's going on for them, not only keeps your emotional bond going, but also your sexual bond as well. So Adair, you'd have a go at some of those questions this evening and see whether your answers are up to date. The other thing that really comes up in our sessions is our need to control. Now, our need to control is built in because it's what motivates us. And what is really, really common is in so many areas of life. You want to do well in a test, you study for it. You do the prep over and over again. If you want to get fit, you get a personal trainer. You do your exercises. If you want to lose weight, you might talk to a nutritionist. If you want to book a holiday, you might book it, but although not sure about that one. And COVID's put a whole new aspect on how we deal with control as well, right? But you get this idea of, usually in most areas of life, if we really want something, we know what to do to get it. And do you know what the key thing is? That we often spend years trying not to get pregnant. Usually very good at doing that, right? But then when it seems like for this starting a family or having a second child, we've ticked all the boxes. We've done everything that we're supposed to be doing, and it's not happening. And then you get these monthly cycles of building up the anticipation and the hope, build, and then the disappointment. And then again, the anticipation, the hope, will it be this time? And then the disappointment. And this urge to control, this feeling of, often what people say to me is, oh, Prue, it's like a roller coaster. It's just like up, down, up, down, up, down. And it's exhausting. Because often what we're trying to do is control what we can't control. And a lot of what we try and help couples do is to get back into the driving seat and to try and refocus between what you can control and what you can't control. And sometimes we'll sit down and write a list of where you can actually impact things. And I just want to cover some of those now. There are lots of things that you can control: how you manage your cycle, how you're monitored, the emotional support that you choose, the time between egg retrieval and transfer, alternative medicines that you do in conjunction with the IVF, when you do your shots, how you do your shots, what information you gather. You decide how long you do the treatment for, and you decide when you stop. So there is actually a lot of things that you can control, and that's where we suggest you put your focus. You can be empowered with these, and with your doctor and with the Virtus team, you can own these. Now, the other thing is that we see is when we're trying to control, particularly things that we can't control, we become very, very focused, kind of zoom in, we hone in on things. And fertility and the desperate need to conceive becomes everything, almost like we've got tunnel vision. And what we try and do in our sessions is just give our couples a chance to pause and to step out and to zoom out again, to perhaps get an idea of how zoomed in have they become and how perhaps can they zoom out. And when you zoom out, often what you notice is the rest of life is kind of still there. We remember who we are. We remember why we're doing it, and we're open to more positive experiences. We remember that we're a team with our partner. We start to share what we're feeling. And there's a kind of quick tool that you can use to have a look at this that we sometimes sketch out in our sessions. And I like to call it the pie tool. And it's basically, how is your pie divided? So if your life was a pie chart of all your different roles, how would it be divided up? And often what we see is, if you're going to kind of divide it into like mental and physical energy, often we'd see that TTC, the trying to conceive, is taking up a lot of mental and physical space. And wife and friend and perhaps work gets squeezed out. And we do this without any judgment. All we want to do is be able to make you feel as comfortable and aware of your choices as you can be. And some people may look at this and go, well, actually, I'm comfortable with that. Others may go, oh, goodness, maybe I need to open up the wife and friend bit. Maybe that would be helpful. So sometimes, and what's interesting as well is when you get couples to do it, it's interesting. It's like then looking at each other's, oh, I didn't realize that was taking up so much for you. Or I thought that would be a lot more than that. And that again starts an interesting discussion of how you're coping and how you're doing and how you want to be doing this journey. So again, maybe have a sketch out of that and see what that looks like for you. And again, there's no judgment, but it kind of starts with awareness and just working out, is it helpful or is it not helpful? And again, there's no right or wrong way of doing this. It's what works for you as a couple. And then a bit more focus on all these things that you can control. So exercise. I don't want to bore you about the benefits of exercise. You know it's really good for you. Sleep is also so important. Getting good rest, particularly during this. And there's simple things, you know, do you have a good sleep routine? No screens 30 minutes before bed, having a high protein snack before you sleep, doing a walk in the evening. There are loads of fantastic sleep meditations. There's lots that you can do to manage your sleep and to manage your rest. And we do have sleep specialists on our team as well. Then nutrition. Lots that you can do to eat right and feel right during this stage. And then the bottom two, ones I'm more interested in because they're more mind, we can control how we interact with others. Yeah, we can control our behaviors. We can decide how we are towards our partners, how we are towards our family. And the other thing is we can manage how we talk to ourselves and how we are with our busy minds. And this is the third thing, right? Oh dear, does IVF and fertility naturally churn up the mind to go, crackers, you know, the non-stop. Now, the thing is with minds, right, is they're useful for loads of things. I mean, really, they are quite useful. We do need them. But a lot of the time, they're not very useful and they don't tell you anything new, particularly when we're faced with uncertainty. Minds don't like uncertainty. If you think about it, basically, minds are evolutionarily designed to do three things. One, keep you safe. Two, avoid discomfort. Three, conserve energy. They're really, really lazy. Because they do this thing called set and forget. They learn a routine and then that's it. They're generally happy with it because it conserves energy to keep using that, then consider something different. So the problem that happens with situations that don't have an easy answer or that we can't fully control is our mind just thinks it's going to be really helpful and think, if I keep thinking over this, an answer's going to come. But the problem is, when you can't control the ultimate outcome or when there isn't a definitive answer, no amount of thinking is going to help. No amount of thinking is going to get a positive blood test. So we can get into trouble when we pay too much attention to our minds, okay? And then it's also even more dangerous if we fight them. So I hear a lot of people just tell me, if I relax, I'll get pregnant. Now, I don't know about you, but when I'm stressed, if anyone tells me to relax or calm down, it does not help. It just makes my brain throw up all the reasons why I am not relaxed and why I cannot calm down. Because as far as my mind's concerned, it's obvious, right? So, but what we do is we're like, oh no, I've got to relax, shouldn't be thinking that, stop thinking that. And it's almost like a beach ball. The worry keeps popping up because your mind knows something's wrong and because this is really important to you. And yet we start playing beach ball, pushing it down, mustn't think that, got to stay positive, got to relax. Oh, yep, stop doing that, stop thinking that, that's not helpful, don't do that, don't do that. And that's exhausting. When we fight our minds, it's exhausting. And what you find is you get these beach balls, these trigger things that are going to set your mind off are going to come up everywhere. You may have pressures from your family. Your parents may want a grandchild and they may get, the little comments in here and there, a little bit of passive aggressive. You doing anything about that? Well, wouldn't it be nice? You'll see as you walk down the street, pregnant women, and your brain as well, because you're thinking about it, its radar is really ramped up and it's going to spot them when other people don't even notice them. Other things, kids playing in the playground, brain's going to go off on one about that. And then blood test results. Do all the numbers, are all the hormone levels at the right level? Should I be thinking this? Should I be thinking that? And then, as you're going through the scans, are the follicles developing? How many there's lots of these worries going to come up. Of course they are. And our tendency is to fight them, to try and push them down. But all that happens is they just bounce back up and it makes us exhausted. So what's the alternative? The alternative is basically to recognize that your mind is only trying to keep it safe. And there's something called name it to tame it, which sounds ridiculously simple, but it's the first way of bringing your mind out of that complete panic mode into, actually gets your prefrontal cortex, your rational brain, back online. Here's anxiety. I'm worried about this. Simply by doing that, rather than go, I mustn't think that, is very different, because, I mustn't think that, makes your mind go, no, there's a problem, got to think about it. Whereas there's anxiety. Yes, I'm worried, is very different. There it is. There's the beach ball coming up. And then thank it and soothe it. Can you say to yourself, rather than, I shouldn't be stressed about this, I need to relax. Can you say, physically hug yourself, release some oxytocins. Can you say, yeah, this is a really difficult time. And I understand that this is difficult. So I'm going to focus on the things that help me. I'm going to focus on soothing myself. I'm going to take power and choice where I can. And then grounding, anything that you can do to help your mind come back to now. Because one of the reasons why we get caught up in worry, you'll notice, is it's generally when your mind's gone to the future and it's thinking, what's going to happen? What's going to happen? Or it's run to the past and it's thought, oh, I shouldn't have done that. I shouldn't have had that glass of wine. If only we'd have started trying 2 years ago. Your mind will do this. Your mind is really only concerned about the future and the past, because usually right now you're quite safe. So anything that you can do to remind your body that you're here now is really, really helpful. Anything like just taking your focus to your breathing, making sure you're not breathing up and down with your shoulders, but you're breathing in and out with your tummy. Something as simple as just pushing your feet into the floor. It's just a signal to your brain that, you know what, right here, right now, ground. Another thing that you can do to help with busy mind is visualizations. And there are lots of apps out there for mindfulness for IVF. There are lots of different techniques that you can use. There's no special way of doing these. You know, people often say to me, I can't meditate, it's boring, and I can't get my mind to stop. That's not the aim of meditation. The aim is to just watch your mind without any judgment. It's to try and come out of that crazy mind sense. And so sometimes we'll share tools with visualizations. Sometimes we'll even do some in sessions. Then the power of thanks. This is another thing that can soothe that busy mind, that can stop it from trying to push down those beach balls all the time. There is heaps of evidence on gratitude. There's one study that actually says people who are grateful are actually 25% happier. It's got great impacts on sleep. It's great impacts on blood pressure, great impacts on overall stress. Now, for me, before I trained as a therapist, I worked in finance and I was an economist. And for me, this being grateful thing was a bit kumbaya, a bit nice and flowery and skipping through the trees. And I was like, yeah, no, what's that about? But the neuroscience behind it is when we're in danger, that radar that I talked about ramps up, beep, 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 and it's always looking for negative things. Whereas once you start looking for things that you're grateful for, it's actually beginning to readjust the brain slightly, just to look out for positive things. And you'll find that if you do a formal practice where you have a gratitude journal, or if you just remember while you're having your first drink in the morning, or when you're, I don't know, having a shower, wherever there's a regular part of your day where you just think, okay, I'm going to think of 2 things that I'm grateful for. You'll notice that as you build it into your routine during the day, you'll start picking up on things. And it may be really big things, like a wonderful partner or a nice place to live, or it may be something really simple, like the sun felt really good on my face as I walked out this morning, or there was a really sweet bird call. Doesn't have to be big. Any of these little changes can help. And then the final thing is the power of pause. Our poor minds, particularly racked with the worry of infertility and the desire to start a family, are very, very busy. They get stuck on this autopilot because I think they're trying to help. But anything that you can do to build in a pause, to just slow down, to just notice where you are and what you're doing, is really, really powerful. And again, I'm not talking about shutting yourself in a room and forcing yourself to meditate for 15 minutes. Just talking about through the day of noticing there's a thought, there's a feeling, oh, I noticed I'm thinking about that again. Any tiny moments of pause are moments where we're just soothing that busy, crazy mind and just taking a moment to just slow down a bit. Any of these activities can help with the busy mind. And the great thing is as well, is these tools can have a big impact on other areas of your life, not just fertility. So I hope this session has given you an idea of some of the things that we cover in our sessions with couples. There is a team of us. We've got varied specialities. We use various techniques. We're trained in trauma, grief. Some of us do family systems. And with Virtus, there are two sessions. There's before you commence IVF, you see us for a 45 to 60-minute session. And then before or around the time of embryo transfer, we have a shorter session where we focus on relaxation and strategies for the 2-week wait as you wait for your blood test results. I'm going to practice what I preach. I'm going to say thank you. It's been wonderful to have the opportunity to share some of what we do here. I hope you found it useful. I hope there's some questions at the end, and I'll pass on back to Pearl.
Thank you, Ms. Prue, for the very meaningful sharing. And I do hope all of you have learned some valuable tips from her. So next up, let us invite Dr. Liao Suilian, Scientific Director of Virtus Fertility Center, Singapore, who will be sharing with you on the art of IVF. Dr. Liao, please.
All right. Hi, good afternoon. Thank you for participating in this seminar. So my topic, as Pearl has introduced, is the art in IVF. What I'm going to talk about are the factors that can influence the outcome of the sperm and sperm. Outcome the IVF, which means the gametes, the sperm, oocytes, and the laboratory. Now, first of all, I'm sure you're familiar with this slide here, but just an introduction to let you know how fertilization happens and in the body, and also the embryos that are growing and all those things, so that you have an understanding how an IVF laboratory works. Yeah. Now, basically, of course, this is the ovary. You have the 2 fallopian tubes. The fallopian tubes are responsible for transporting the sperm to meet the egg, and also from the embryo back to the uterus. Yeah, and this is the vagina here. So as you know, every month the woman will ovulate, and the egg will be sucked into the tube here, and the man will deposit his sperm in the vagina here. So there will be millions of sperm competing among themselves like a marathon race, because you have some fast swimming sperm, slow swimming ones, and then some don't swim at all, and some just swim in circles, and then they have to swim all the way to meet the egg here, and fertilization happens in the tube. So now, once the egg has been fertilized, we don't call it an egg anymore. You call it an embryo, and this little embryo will need to travel down the tube to reach the final destination in the uterus, so that you can implant and get food from mommy. So it takes about 5 days for the embryo to reach here. So during the 5-day journey, the embryo, of course, will grow more and more cells. And by the time it reaches here, it's become a blastocyst. All right. So now, how does a blastocyst look like? This is how it should look like. All right. So now, a blastocyst is the final stage of embryo development before it implants. So it's so specialized that you can see by then 2 distinct groups of cells. One blob is this one will give rise to the baby, and this network of cells will give rise to the placenta. Now, fertilization, as you know, is a union between the sperm and the egg, so that you can produce an embryo. Now, what you see on the left side is a human egg magnified to about 5,000 times. As you know, a human egg is just a size of a full stop on a page of paper. So what you see here is just like a tennis ball, and it's those like yellow things. So these are the sperm that attach to the surface of the egg. And on the middle picture, you see the sperm are attaching on the surface of the egg before going in and fertilize the egg. All right, so this is just a diagram here to show you the sperm that will stream all the way here and trying to fertilize the egg. And the sperm itself also wears a cap. Now, the cap is very important because the cap contains an enzyme that helps the sperm to drill a tunnel through before going in and fertilize the egg. But not, of course, every sperm will have such a nice cap. So there will be some with spore cap and those beta enzyme and can't penetrate completely and get stuck in the eggshell and can't fertilize the egg. And some sperm don't have any cap at all. So this sperm will be swimming around and can't fertilize the egg naturally. So they need help to go in and fertilize the egg. All right. Now, first of all, what do we have to make IVF successful? Of course, the first thing is to select a healthy sperm. Now, as you know, man produces millions of sperm. So out of the millions, there will be a small percentage of the sperm that have normal forms, like what you see here on the left side. The normal form sperm looks like the head. It has a head here that is oval in shape, and that head contains the male DNA. The neck is the powerhouse, and the tail is just to help the sperm to propel towards the egg. Now, you have millions of sperm. Of course, there will be some defective sperms, like those defects with the head defects, large head, small head, and all this. This will affect the sperm swimming towards the egg fast enough or attaching to the egg surface before it can fertilize the egg. Or the neck problem, same thing. And the tail problem, some can't even swim. Short tail swim very slow, and this double tail, yes, swim very fast, but it's defective. So overall, when you come for the semen analysis, the most important is to look at the sperm count and then look at how many % of the sperm have normal shape, so that you can see whether the sperm can, the semen that is produced by the man can fertilize a woman's egg naturally, or they need help to fertilize the egg outside the body. Now, when the man submitted the sample, what happens in the lab will look at some parameters here. First of all, of course, we look at the concentration. Concentration means number of sperm that is found in 1 ml of the semen sample. And on your right side, these are the latest WHO parameters, the minimum number of values that the person should meet. So let's say if the man has 15 million or more, so he has no issue with the sperm count. Anything less than 15 million, probably he has a problem in fertilizing, trying to get his wife to conceive naturally. Motility here is based on progressive motility, meaning how many % of the sperm are moving forward towards, how many when swim forward towards the egg. So minimum would be 32%. Vitality here means how many % of the sperm are alive. Yeah. So now not every sperm that is ejaculated would be alive, because there will be some dead sperm. So minimum about 60%. Morphology, as I mentioned earlier, the normal forms, how many % of the sperm should be normal. Anything less than 4%, that means probably the man have difficulty, making his wife pregnant because of the insufficient number of sperm that have good forms. Yeah. Now, this slide here just to show you how we prepare the sperm. Now, when the man comes for IVF or for IUI, what happens is that we need to process the sperm. All right. Now, the purpose of processing the sperm, of course, is to harvest the best sperm from the sample, so that you can use that sample to fertilize his partner's eggs. Yeah. Now, what you see on the left side, this is the unprocessed sperm sample. Now, you see some are swimming sluggishly, some don't swim very dirty. Yeah. And after processing, you see majority of the sperm are swimming very fast and it's very clean. That's when we use it for fertilized IVF or IUI and so on and so forth. Now, over here, what we do here is we have this procedure here. Now, ICSI, or Intracytoplasmic sperm injection, meaning selecting a good sperm to inject into the egg. Now, this is commonly used in most IVF centers, and what it means is that you inject one sperm into the egg, so that you make sure that the sperm is inside the egg on the same day of egg retrieval, and the sperm will have at least 70% chance of fertilizing this egg. So, in other words, let's say you have 10 eggs injected, at least 7 get fertilized, and most of the time it's 100%. Now, there are some terms in the report. They say the man sent up the sperm for semen analysis, and the report came back And these are some of the terms that you may be familiar with. Now, oligozoospermia means low sperm count. Terato means abnormal sperm morphology, meaning that less than 4% of the sperm have the good shape. Yeah. Actinospermia means poor sperm motility. That means the less than 32% of the sperm have progressive motility. All right. So now, when it comes to this type of condition, Icsi can be used, or IVF. IVF in layman terms means mixed assisted reproduction, but in clinical terms, in the body terms, means you mix the egg and the sperm together so that the sperm can try to fertilize the egg naturally. But this IVF procedure is not suitable for every sperm condition. So you may, if you were to apply to every sperm condition, there's a risk of poor fertilization or even zero fertilization. All right. So in some conditions, Icsi is recommended. But now over at Virtus, what we do is that we do IMSI, which means that intracytoplasmic morphologically selected sperm. That means that before the sperm is injected into the egg, the sperm is selected at high magnification so that to make sure the best sperm gets into the egg. This will help to improve the chances of getting good embryos and also a better outcome for the patient. Yeah? Now, the next thing is, what's the outcome? Now, another factor could be most of the time, people have been talking about, okay, the job of the sperm is just to get in and fertilize the egg. But there are now currently a lot of evidence that shows that the sperm quality, especially particularly its DNA quality, has an impact on the outcome of the pregnancy. So far as the first 3 months of pregnancy. Now, what happens is here, you can see the two pictures here of the embryos. Now, these two embryos were derived from sperm that had badly damaged DNA. So much so they can't even reach the blastocyst stage. So the woman may get embryos naturally in her body fertilized, but the embryos couldn't reach the blastocyst stage and she couldn't get pregnant. Or in IVF terms, can't reach the blastocyst and you can't get pregnant. Now, but let's say this embryo managed to reach the blastocyst stage, pardon me, but because of the damaged genes contributed by the poor sperm DNA quality, even if it reached the blastocyst stage, it implants, the woman gets pregnant, she has a higher risk of miscarriage or pregnancy loss. So over here, what we do is that, how to do that, how to identify the quality of the sperm. In addition to the semen analysis, we do sperm fragmentation assay. And what you see here on the left side is that basically what happens is that the sperm, a sample of it, will be treated with chemicals to break down the cell membrane so that the DNA is spread out. All right, so this is sperm head and it's spread out and it forms a halo. So this test is known as halo-sperm assay test, yeah, sperm test. So the size of the halo can tell you the quality of the sperm DNA. So in this case, the large halo, that means that this sperm had good DNA. All right. Now, this sperm here, shows you that more than 50% of DNA has been damaged, or sometimes even no halo at all. So this one tells you it's 100% damage. So what happens in the laboratory is that the laboratory will add up the sperm that have small halo plus the sperm that had no halo to derive the sperm DNA fragmentation index, known as PFI, and the smaller percentage, the better the quality of the sperm DNA. Now, what could have impact on what the factors can affect the sperm DNA quality? Now, there are some lifestyles, like heavy smoking can cause the sperm DNA to degrade. Too much alcohol consumption, there's also an indication that it can cause the sperm DNA to degrade. Chronic exposure to pollutants in the environment, like particularly those, I can see more those working in chemical and oil industries, where they can breathe in all those volatile compounds and all this and that. Exposure to radiation, like those working in, I see more in the IT industry, as well as the airline industry, the stewards and the pilots, and they can see more of them. Yeah, even engaging in a recreational sport like cycling, especially when you see some cyclists, spending 1 hour, 2 hours cycling tens of kilometers, and the growing area is on the saddle and it's so heated up that can also cause damage to the sperm. All right, but all this can be overcome if you take some precaution, like if you know what you're exposed to, so you reduce your exposure to that factor, or you take some supplements, and the doctor can advise you on how to manage that. Yeah. Now, how in the laboratory, how are we going to identify a good sperm from the best sperm? Now, what you see here, using, as I mentioned before, by default, Virtus uses IMSI, and what you see here, high magnification here. Now, this sperm are magnified at least 1,200 times. All right, and what you see here, those that you see on the holes on the head, we call it the vacuoles head. This shows you that this sperm had badly damaged DNA. All right, so this sperm will be selected out and will not be used to fertilize the egg. All right. Now, you may wonder how all these holes come about. Now, this is a very high magnification of full sperm head, electron micrographs, and what you see here, the dark matters are the DNA material, and as you know, we always taking in impurities from the environment, like food, water, air, all the time. So all these impurities go to the blood system, generate what we call free oxygen radicals or reactive oxygen species that have affinity towards DNA of any cells, including the sperm. So these free oxygen radicals will break down the DNA and create empty spaces in the head like this. And what you see here, sperm 1, sperm 2, and sperm 4 have badly damaged DNA. So when you look from top down, these empty spaces look like holes on the head. So that's how they are identified and rejected. So over here, we will take time to look for the best looking sperm to get into the egg to improve the chance of you getting a good outcome. Now, the next thing is how we select the egg. Now, this here shows you all the eggs that are defective. Yeah, you have some inclusion body, all these things here, some vesicles, yeah, granulation, all these things, vacuoles and high holes, all those things like that. These are the eggs that could not generate good quality embryos. All right. So now some of these eggs can be found in 1 or 2 of the cohort. Yeah. But sometimes you may see many of these. So if we come across this type of eggs, we will not fertilize them because the embryo quality, and most of the time the genetic outcome, these embryos may not be able to effect an implantation or pregnancy, or had a higher risk of miscarriage. But in this instance here, for this egg here with the egg here that is too thick, most likely then the sperm can't fertilize the egg. So this one probably can give rise to a healthy embryo and pregnancy. And we have some patients who have very thick eggshell who have been delivered a few live births already. Yeah. So now, how do we select the egg? Now, in most IVF practices in the world, you assess the quality of the egg by visual assessment, visual grading. You will look at the egg here. The egg looks good, very nice, good potential to produce a good embryo. But at Virtus, we are more interested, in addition to that, is the makeup of the internal makeup of the egg itself. And this is what we call a structure here, a spindle, meiotic spindle with the chromosomes in here. All right, the whole structure should be healthy that way. Now, the white lines here shows you the 23 chromosomes that are retained in the egg for fertilization. The other 23 chromosomes are thrown away in here. This is a rubbish bin for the egg. And the purple here are the so-called the strings that attach to each chromosome that are responsible to separate the chromosomes evenly during cell division. And when the sperm comes in and fertilize the egg, the sperm will contribute 23 chromosomes plus the 83 chromosomes. That's how it makes up to 46, which forms a human being. Yeah. So now, of course, we can't treat the egg with these chemicals. So what we use light from the microscope that goes through a series of polarized filters. Yeah. So what you see here on the left, on the right side here, now just before the egg is injected into with the sperm, the egg looks healthy, but we want to see how healthy the structure is. So by using the polarized light to shine here, you see a reflection here. Now this is bright, and this reflection shows you similar shape as the spindle. So this egg that tells you that it has good potential to give you a good embryo, lower risk of miscarriage. Now, in this case, you see this egg looks healthy, but internally, when you look at it, the chromosomes are stuck between the small cell and the egg. So that means they are not completely separated. An embryo that derived from this egg will be genetically not healthy and higher risk of miscarriage. Or this egg here, it looks healthy on the surface, but internally, this structure has been broken into pieces. Again, the embryo that derived from this egg will be genetically not healthy, higher risk of miscarriage. So in the laboratory, when we come across this type of eggs, we will not fertilize them. We only fertilize this type of egg. But let rest be assured that majority of the eggs will have this quality here. But you only see more of the defects on this structure here when we have patients who have history of recurrent miscarriages, or maybe those women in their 40s. Yeah. Now, this is just to show you the defects here. What you see here, this is the normal spindle that I showed you earlier, and these are the defects that we can find in the egg itself. You see the structure is different, yeah, and this affects the separation of the chromosomes during cell division, and it will generate genetically abnormal embryos. Now, the next thing is growing the embryo and also selecting the best embryo. Now, this slide here shows you the 5-day development of the embryo, and this is the 24-hour interval of embryo development. So at the end of each interval, the embryo should reach a specific stage. Let's say, for instance, on the second day after egg collection, 2 days should reach by end of 24 hours, 48 hours should be 4 cell, and then 8 cell, and so on and so forth. Now, what you see on the first slide here, this is how a fertilized egg looks like. Yeah, there are 2 round things here. One of them is known as a pronucleus. One is contributed by the egg. The other contributed by the sperm. Yeah, all right. And what happens is this. Yeah, growing the embryos. How embryos are being grown. Now, there are 2 methods of growing. Currently, two ways of growing the embryos. One is now currently most common now is the box-like incubator, whereby you, in order to monitor the progress of the embryo, every morning the laboratory have to take out the embryo from its comfort zone, put a microscope, and then check and put it back again. Now, the more times you take out the embryo and check, the more stress it causes the embryo, and the embryo may not be able to reach the blastocyst stage, or the blastocyst that you attain may be of poorer quality. Yeah, and that can affect implantation. Now, what happens in Ivf is that we grow the embryos in a time-lapse microscope, incubator, whereby the embryo is not taken up for its entire 5 days of development. Let it grow quietly, because there's no need for us to take it out, because there's a camera on top of each valve that the embryo is growing. Now, this camera, every 10-minute interval, will take a snapshot of the egg and embryo for its 5 to 6 days of development. So let's say by the time it reaches the blastocyst, this incubator will compose all these images into a video, so that the lab can review and grade them, and even with AI, you can the embryo with the best score will be transferred back to the patient with a good outcome. Yeah. So what you see here is how the embryo develops from now 4 cell to 8 cell, and then you'll see more and more cells coming up. And now it's going to become a blastocyst. So a healthy embryo is formed, Yeah, and this one will give rise to the baby, and this one gives rise to the placenta. All right. Now this is one this is one of the incubator. This is the incubator that we use. It's called Embryoscope or time-lapse incubator, whereby the embryos are grown in here and they can be monitored in real time without taking them out. Yeah, and at the end of it, the videos of the embryos are downloaded to a thumb drive, and then we can give back to our patients for for keeping. Yeah. Now, another important things the factors that can also affect outcome is the laboratories. Now, what you see here, our laboratory is ISO certified clean room. That means the air quality is premium. And on the left side, embryology, that means that when we will prepare the sperm for IVF or for IUI, and this is embryology work where eggs and embryos are handled in this crib here, where the controlled environment to minimize stress. This fertilization is happening here. And these are the box incubators that we used to use, just to show you, but from 2020, we have started using the time-lapse incubator, and the frozen embryos are all stored in liquid nitrogen, all in a safe and secure area. Yeah. And just the last one here, just to show you the outcome here. They give you the 2019 data. That is because babies conceived the year 2019 all would have delivered last year, so that I can give you what's the probability of you taking home a baby. Now, a bit of information here. OPU means number of egg collections or number of women who came for IVF. FET means frozen embryo transfer. So we do a lot of frozen embryo transfer here, and you will notice that the FET is more than OPU. That is because some patients who did their IVF in late 2018 will have crossed over to 2019 for transfer. Yeah. Now, the average age of the woman here is 37 years old, and majority of them have had one failed attempt elsewhere before they come to Virtus for treatment. And and for the first embryo transfer, they have about 70% chance of getting pregnant. Yeah. And all this data here only includes those couples who use their own eggs, own sperm, and embryos that have not been tested for genetics. All right. So this is to give you the true picture. Now, the green bar just tells you the clinical pregnancy. Now, clinical pregnancy is defined as a pregnancy when you see a fetal heartbeat on the first ultrasound scan. Now, when you did embryo transfer, 2 weeks later, you go for a blood test. Blood test tells you are pregnant, but that is not confirmed yet. Not confirmed pregnancy. 2 or 3 weeks later, the doctor may appointment, you see the doctor for the first scan, you see a fetal heartbeat, then that is considered as a clinical pregnancy. Now, LPR means live birth. What's the chance of you delivering a healthy baby? All right. Now, there's a difference between the drop here, pregnancy and live birth. That is because of the miscarriage rate. And as you know, in normal pregnancy, there's also a risk of miscarriage. But at Virtus, we try to minimize that miscarriage rate for the couple by selecting the good egg, good sperm, and producing at least a good embryo for transfer. All right. So at that, I end my talk. Thank you very much for your attention.
Thank you, Dr. Liao, for the very eye-opening presentation on the science behind IVF. Okay. Now, don't forget, if you have any burning questions that you have in mind, please feel free to drop them into the chat box for our Q&A session later. Next, for those of you who are harboring thoughts on what exactly goes on during an IVF journey, you'll be very keen to find out more from our last speaker today, Dr. Andrew Khan, our fertility specialist from Virtus Fertility Center, Singapore. Dr. Khan, please.
Thank you. Thanks, Paul. Just checking whether you can see my screen.
Yes.
Okay, good. Good afternoon, everyone. Thanks for taking out your valuable time to be with us this afternoon. And I hope it will be an informative afternoon. So you've heard the first two speakers, and I'm going to give you the IVF journey and how it can really be quite simple, right up to the stage where, the eggs and the sperm goes to Dr. Liao, and then he deals with it in the laboratory. But before I do that, I'd just like to introduce myself. I've originally from Singapore, but I've been away in Sydney for about 40 years, apart from the 2.5 years that I did national service. In the last 20 years, I'm basically just doing infertility and IVF. And despite what's been happening with the COVID situation, just let me see whether I can change the slides. Yeah, is that a new slide? Is that a new slide?
Yes.
Yeah.
You can see on the next slide.
Yeah, despite what's been happening with the COVID situation, infertility or IVF in general, we're not talking about just Singapore, but Australia, around the world, has increased quite a lot. The number of cycles have increased, and in Virtus in Singapore, we've had a record year. So I'm very happy to come back and try and help out the doctors here and the scientists to try and go through the cycles. So we're all very cognizant of COVID, what's happening. We want to try and help the patients. There are lots of things that we are doing to try and help the patients. For myself, I will be trying as much as possible to do Zoom consultations with the patients so that the patients don't need to come in. All right. Okay, but let's start with what I want to talk about today, and that's really about the IVF journey. But IVF, that process is called in vitro fertilization. It's a very specialized term. When you talk about IVF, you're really talking about, at the end of the day, you need to take the eggs out from the woman, you need to get the sperm from the gentleman, and you need to put this sperm and egg together in the laboratory. Dr. Liao has shown you some of the ways they do it. And then that in the laboratory is where fertilization happens. So that is in vitro, the Latin word in vitro, so basically outside the body, fertilization, as opposed to in a normal situation, fertilization happens in the fallopian tube of the woman. But really, before we get to that point, and I like to reiterate some of the things that Prue talked about. We should really be thinking, okay, why aren't we getting pregnant? Are there things that we can do to help us get pregnant naturally? So before we get to that stage, and I do apologize, I know that there are patients here that had different stages in their infertility journey, but really before you actually even start thinking about IVF or infertility treatment, there are certain things that you can do to try and improve your chances. So the slide shows, things like really common sense things, coffee. I'm not saying that you need to stop coffee altogether, but most of the studies said that anything more than 6 cups of coffee, and I think 6 cups of coffee is quite a lot of coffee, is going to be detrimental to your fertility health. Alcohol, I would say, try and cut it down, especially once the woman gets pregnant, she should have 0 alcohol. Before that, just minimal. And all the things that Prue was talking about, healthy diet, exercise, definitely stop smoking and try to control weight. But having done all that, and we're trying naturally, we're still not conceiving. Why are we still not conceiving? It's pretty common. We're talking about 1 in 6 couples that need some sort of assistance, not necessarily IVF, but 1 in 6 couples need some sort of assistance. And the reason for it, divided, quite equally. 1/3 of it is female, 1/3 of it is male, and then 1/3 of it is a combination between female and male. So male, it could be like some of the sperm parameters, like there's not enough sperm or the sperm's not moving. Plus, the woman might have some of her own problems like tubal issues or polycystic ovaries or endometriosis. So 1/3 of it will be a combination of male and female factor. But that just leaves 10%. So 10% of couples, no matter what investigations we do. The sperm parameter looks good. We've checked her. She's ovulating every month. The fallopian tube is patent. We've done some imaging, and the uterus is fine. There's no fibroids. There's no polyps. And yet the couple's still not able to get pregnant. So this 10% we call it unexplained infertility. The first journey after you realize that you do need some help is to make an appointment to see a doctor. Okay, it doesn't necessarily have to be one of us infertility doctors. It could be your general practitioner, and your general practitioner or the infertility doctor will go through your general history, talk about timing of intercourse, whether the periods are regular, whether she's ovulating, and then do an examination, ultrasound, make sure the pap smears are done, organize some basic fertility testing. And the most basic fertility testing is the semen analysis, which Dr. Liao has mentioned. The other thing that we would like to organize is to check the tubes to make sure they are patent and to look at the number of eggs left in the ovaries. This is called the Ovarian Reserve. I'll talk a little bit more about that. So ovarian reserve is the number of eggs left in the ovary. Women are born with a fixed number of eggs in the ovary. So when the woman is in her mother's womb, she is already starting to make the eggs. But up to about 20 weeks, when her mother is 20 weeks pregnant, the number of eggs is already peaked at 20 million eggs. And after that, after 20 weeks pregnancy, the egg numbers do not increase. They just keep decreasing. So from 20 weeks of pregnancy until the baby is born, the female baby is born, that number keeps going down. And even though she hasn't started her periods, and even though she hasn't started menarche and is not ovulating, during the time that she's born, right up to the time that she has her first period, which usually is in Singapore or around the world is about 12 to 13 to 14 years old. Up to that stage, the number of eggs keep dropping. And we're not talking about dropping very slowly. We're talking about dropping quite a lot. So this slide here shows this fact that, it peaks up here. And then this is time when she's born. This is about, it actually goes up to a bit higher than that. And then it goes down. We're talking about millions of eggs. So this shows number of eggs. This is at the time of birth. You can see it just keeps going down. She does not make any more eggs. Unlike men make sperm every 72 days. They keep making sperm. So, if there's some issues that he's been unwell, there's a drinking episode that basically affects the spermatogenesis, the making of the sperm. If you wait and you just lead a good, healthy life, 72 days later, there'll be a whole new batch of sperm. Whereas in the women's situation, that number of eggs just keeps decreasing, okay? Although we start off with, very high numbers, I said 7 million, it will keep going down. So by the time you get to puberty, that's when the woman starts having her first period and she's ovulating, there is only about 400,000 eggs left, okay? That might sound a lot, but every day she is losing eggs, and she's losing hundreds of eggs, okay? By the time she reaches the menopause, then there will be no more eggs in the ovary. So this is why this test is a blood test, anti-Mullerian hormone, is such an important test, because it is a blood test that tells the woman how many eggs there are left in the ovary. And the results of that blood test is not just a number that's good or not good. It is in relation to her age. So as she gets older, this AMH level gets lower and lower, and she's still within her normal limits. What we are worried about is the 30-year-old woman that does the AMH and then comes back with a figure that is not consistent with her age. It shows that, okay, there are eggs in the ovaries, but the number of eggs is consistent with someone that is 40 years, 45 years of age, okay? It doesn't mean she cannot get pregnant. It just means that in her case, we need to rush things. We don't have that luxury of time, even though by right, she's, in her early 30s, and we should have more time than not. So this is the way the results come back with a anti-Mullerian AMH. So on this side is the level, the AMH results, and on this axis, the x-axis is the age. So if you are, say, 34 years old, and your value comes back up to here, this is the normal range. The green is the normal range. So it comes back at this level. Okay, say this is a logarithm score. So say it comes back at 20, 25, then that's within normal limits for her age. But if she is 43 and the level comes back at about 6, 7, that's actually the normal value for 43 years old. So that the results come back like that, and it needs to be interpreted by the doctor. Other things besides, a low number of eggs in the ovary, simple things. Dr. Liao showed you a picture of the fallopian tube, and it's important to realize, not many people know this, that fertilization actually happens. So the sperm penetrates, this is in a natural situation, the sperm penetrates and fertilizes the eggs inside the fallopian tube. So if there is a blockage in the fallopian tube, and especially if there is a blockage on both fallopian tubes, then this couple is going to have problems getting pregnant, even though she's ovulating every month, she got lots of eggs, and his sperm is super, super good. But because the fallopian tubes are blocked, and because they're blocked on both sides, then the sperm can never reach the eggs. Okay. Other conditions that some of you might come across: polycystic ovaries, endometriosis, fibroids, and this failure to ovulate. I'm not going to elaborate. These are just things that common female fertility issues. Men's side, very simple. I mean, I'm not talking about how healthy he is, how much he's smoking, how much he's drinking, all of which he really needs to cut down or cut off completely. But from a fertility point of view, the best, or currently the best screening tool is a semen analysis. So I would say, maybe even before you see the doctor, or definitely if you see the doctor, the first test that he should be ordering is a semen analysis. No matter how healthy or how great the guy looks, okay, or is how fit he is, okay, he still needs a semen analysis. It's such a simple test, and it's really worth doing first before you subject the woman to blood tests to look at anti-Mullerian hormones, ultrasound tests to check whether the tubes are patent. Because if the sperm comes back has really bad, or sometimes even no sperm, like azoospermia, then it's a different track we need to go down, okay, rather than subjecting the woman to all these invasive investigations. But the thing to note about semen analysis is it's not a value, and that value is not always the same. So this is an interesting experiment. This is it's a prisoner, actually. A prisoner, he was locked up in jail for a few years, and he volunteered to do this experiment. We know he is fertile, so we know his semen analysis is good. What he volunteered to do was to give sperm, a sample of his sperm every week for 2 years. So 120, this is weeks, so 120 weeks. And this is the sperm count. This 20 here, this 20 million sperm per mil is the World Health Organization 2010. That is the current guidelines for normal sperm count. So normal sperm count is 20 million. Anything more than that is good. So he gave a semen sample every week for 2 years. And look at this value. So if he gave it around this time, then obviously we will say it's all normal, 60 million, 80 million, very, very good. He can become a donor. But just look at some of these times. So let's say he gave a sperm count here, okay? For a coincidence, he just went to see a doctor with his wife, and then they ordered a sperm count. It came back at maybe 1 million sperm per mil. So panic. So that must be the reason for his this couple's infertility. But the fact of the matter is, if you repeated it, remember I said men make their sperm every 72 days. If you repeated it a few weeks later, or 1 or 2 months later, we usually say try and repeat it 72 days later, because if it's bad, today and you repeated it next week, it's still the same batch of sperm, so it probably won't be that good anyway. So if you wanted to, if you're thinking, okay, there must be an issue with this variability, maybe he had some binge drinking about 2 months ago, let's wait for another 2 months and then repeat it. And if it comes back normal, if you have a sperm test is normal, then he is basically normal. So it's such a simple test, but except for some of the downfalls, pitfalls that you need to know. If it's bad, you repeat it, and if it's good, then you basically, from a fertility point of view, if the sperm test is good, we can more or less rule the man out of the equation. There are more sophisticated tests that you can do, and Dr. Liao's mentioned the fragmentation testing, more sophisticated, but this is the simplest and easiest screening test you can do for the men's side. I won't talk too much about this. These are the pictures of that Dr. Liao has shown before, some of the abnormal sperm. So it's not just about good numbers. You can have lots and lots of sperm, 30, 40 million sperm, but if the sperm is not moving, so this is called a motility problem, then you have a problem. Because sperm, when you have intercourse, is deposited at the top of the vagina. It still needs to swim from the vagina, through the cervix, through the uterine cavity, into the fallopian tube, where fertilization takes place. So even when it gets to the fallopian tube, it still needs enough energy to penetrate the egg. So if the motility is bad, first of all, it's not going to get to the fallopian tube. Second of all, if it gets there, fertilization is still going to be an issue. And the third thing about semen analysis is the shape of the sperm. So this shows normal sperm, and these are abnormal two-headed sperm, small head. These are multiple tails, sperm that swim round and round and round. They're also not going to be any good. So you need good numbers. You need the sperm to be moving, but you also need normal morphology sperm, one oval head, one tail. Okay, so once we've done all the investigations, you go back to see your GP or your fertility specialist, and then they talk about whether there are issues that need to be sorted out. If you sort them out, you can start about, okay, how can we help you get pregnant? It may be as simple as trying to time the intercourse a little bit better, try to in terms of your habits, quit smoking, drinking, and all that. And although I'm very quickly going to talk about the simple IVF, I also want to talk before that there are other methods, besides before you reach IVF that you might consider trying, depending on the blood test results. Okay, if you have problems timing your intercourse, let's say the periods are very irregular, in the 28, if a woman's periods are 28 days, then it's pretty simple. You probably you're ovulating on day 14, you just have intercourse around that day. But if a periods varies, sometimes it's 21 days, sometimes 35 days, it's very irregular, or worse still, she doesn't have any periods, then it's very difficult to pinpoint when she's ovulating. So we can do things like, monitor cycle to see when's the best time to have intercourse. We can, if she's not ovulating by herself, that means the most common condition is this condition called polycystic ovaries, then we can think about using oral tablets to make her ovulate, or injectable tablets to force the ovaries to come out with the eggs. And one step before IVF, in vitro fertilization, is this procedure called Intrauterine Insemination, IUI. So the word itself gives you a clue as to what's happening. We are going to be putting a fine tube through the cervix, and we're going to inject the washed sperm. Dr. Liao mentioned that once you give us the sample of the sperm, he showed you a nice video of the sperm that wasn't washed, and the sperm sample that was washed. That means a lot of the debris, the dead sperm is gotten rid of. And you put this very, very concentrated motile sample or sperm into the uterus. You usually do this in association with either oral tablets or injections to try to make her, in this case, you can see that she's ovulating 3. So basically, we're trying to increase the number of eggs, the number of targets for the sperm. If I don't give you any oral tablets or injections, then if you're ovulating naturally, you usually ovulate just 1 egg. So we're trying to increase the chance of spontaneous pregnancy in this situation. Okay, let's move on to IVF and Icsi. And Dr. Liao has talked about this. IVF is what I mentioned, what happened in 1976 with the birth of Louise Brown in Cambridge in the United Kingdom. They just took the sperm, they got the egg, and they washed the sperm, and they just put the sperm onto the egg. So they let the sperm, this is like hundreds and thousands of sperm, concentrated sperm. They try to let it fertilize the eggs naturally, and that was IVF. In about 1991, 1992, Palimo, I think, was in Belgium. He's an Italian scientist, and what he did was, the sample of sperm that he got from this man was so poor that he said that if he did this IVF, just pour, concentrate and pour, there wouldn't be enough sperm to have fertilization. So maybe if he had 10 eggs and he tried to do IVF, the next morning, none of the eggs were fertilized. So he thought about, why don't I pick just one sperm, good looking, like normal looking motile sperm, and I put this needle straight through the egg, and inject the sperm into it. So intracytoplasmic, that's the main body of the egg, sperm injection. So that's abbreviated to ICSI. So that was invented in 1991 for men that have very low sperm count or poor motility. So there are two, although we still call this IVF, but just for nomenclature, one is strictly IVF and the other one is Icsi. But the whole process nowadays is become, when we first started, way back, we were mixing powder with fluid to make the injections, the FSH. And then it was a very painful injection. You need to give it intramuscularly. Nowadays, it's a pen. It's like an EpiPen or the diabetic pen. You just dial the dose and you put it up against your skin, just any skin. So it's subcutaneous and you inject. So it's so simple. You inject yourself once a day. And this is the FSH, follicular stimulating hormone, which is a hormone that normally comes up from your brain anyway, but we're just giving it in higher doses so that we try to make your ovaries produce more than its 1 egg that month. So if I don't give you these drugs, you produce 1 egg, but now I'm not doing IUI, I'm doing IVF, so I don't want just 2 or 3, I want 5 to 10, I wouldn't say the more the merrier, because the more if you get really, really big numbers, you also get very uncomfortable and at risk of complications. So I think 5 to 10 is a good number. We try to get that number of eggs from you. And to do that, we need to give you daily injections for about 10 days. So nowadays, it's so straightforward. It probably takes about 2.5 weeks of your time. Period comes, you start the injections. We would have taught you how to do the injections, and basically you do the injections yourself once a day. You or your partner can do it. We will be doing blood tests and ultrasounds along the way to see how you are developing, whether the eggs are coming out, whether your hormones are rising. Usually about 10 days of injections before we do the egg collection. Egg collection is done under general anesthesia, very, you're sedated, you can't feel anything at all. Takes about 20 minutes to do it. We go through the vagina, so we got a transvaginal ultrasound, we got a needle. It goes through the vagina straight into the ovaries, and then we suck out the eggs one by one. Takes 20 minutes, and you're awake, you go to recovery, stay there for an hour, make sure you can pass water, have something to eat or drink, and then you go home. Okay, so straightforward. So that takes about, we already said, about 10 to 12 days. We're up to here. Dr. Liao mentioned that once we've got the eggs, we pass it to the scientist in the lab. The husband gives the sample to the lab. The scientist in the lab puts the egg and sperm together. So it's either done by IVF or Icsi. So once fertilization happens, again, Dr. Liao has shown that we grow the embryos for 5 days. Then we will choose the best embryo to put back into the uterus, or we can freeze all the embryos so that she basically, the woman will have a rest for a month and then she can come back later to put it back in. But if we do what we call a fresh embryo transfer, you can see that, from the time you start injecting to about here, it's about 2.5 weeks of your time. And then that's done. So after that, it's, I think Prue mentioned, it's just a 2 weeks waiting game to see whether you're pregnant or not. Okay, I think I'm running out of time, so I'm not going to talk about this part. I want to mention embryo freezing because embryo freezing is something that Virtus is very, very proud of. Used to be, we always went for a fresh embryo transfer. Why? Because when you freeze the embryos, let's say you collected 10 eggs, and in the end of the day, you got 5 fertilized, and out of 5 fertilized, you end up with 3 really nice blastocysts, okay? So we put back 1, and then we will freeze 2. So that's the usual process. In the old days, we always try to put back fresh embryos because the freezing process in the old days wasn't very good. You have to bring the embryos down to -196 degrees, liquid nitrogen. Then when she's ready to be used, you need to thaw it out. The old days, the slow freeze process, we lost a lot of embryos in the freezing and thawing process, and the quality of the embryos that were frozen, thawed, wasn't as good. Nowadays, with the process, and like I said, of vitrification, and we are particularly proud of the results here at Virtus, is that almost all the embryos you freeze will survive, and the pregnancy rates from a frozen thawed embryo is just as good as a fresh embryo transfer. I think that's all. We talked about this. Is after we put the embryos back in, about 2 weeks later, we will have a pregnancy test to see whether she's pregnant or not. And then that's not the end though, because Dr. Liao showed slides that there is a chance of miscarriage. So certainly we will be monitoring that pregnancy very carefully. And finally, we'll be doing a scan about 2 weeks later to see whether we can see a heartbeat. Okay, I think that's it for me. I'm happy to take any questions. I'll pass you back to Pearl.
Thank you, Dr. Khan, for the very insightful presentation. So now we're down to the last part, which is our Q&A. Please keep your questions coming in. I do have some questions that I have. So maybe I'll start with the first one, that is to Dr. Khan. The question is, what should I do if I want to increase my chances of pregnancy through IVF?
That's a very, very good question. And I think the answer to that question is, if you ask 10 different IVF doctors, you will have probably 10 different replies. For my reply is that I think a lot of what we do takes what you need to do out of your hands. So we are going to be stimulating you with hormones. So the hormones will directly affect the ovaries and make you produce more eggs. Husband will give us a sperm. Once we collect the eggs, it's all really up to the scientists. So I'm going to say that, from the IVF part, what we do, there's not a lot I would recommend. But all the things that, Prue has been talking about, all the things that I did mention about before you start even thinking about getting pregnant, lifestyle habits, stop smoking, cut down on drinking, all that, should really be sorted out. That is to make, at the end of the day, the gametes, which is the egg that we collect, and the sperm that we get, because Dr. Liao can only do what he can do with the things that you're giving him, okay? And if they are not of the best quality, then that's going to be an issue. But I'll let Prue take on some, maybe she want to add to this.
Yes, Prue, do you have any wellness rituals to share with us, couples who are wanting to prepare for IVF?
Yeah, I mean, thank you, Pearl. Another great question. You know, along with some of the ideas that I shared in my presentation, I think, you know, one of the things that we always encourage couples to do is kind of know your coping mechanisms, know what works for you. Know what makes you feel good. You know, is it a new hobby? Is it listening to feel-good music? Just, you know, having a list of your go-to things that you can do that are going to soothe you, that are going to stop that the busy mind. And, you know, I think as well as part of that is knowing who your support network is. Who can you turn to, you know, when you're having a bad day? Even if it's just a journal that you write in and it's not actually, you know, a person. So knowing, really stopping to think what works for you, because when you're in it or when you're panicked, you're not going to press that pause, or it's more difficult to press the pause. So forewarned is forearmed, I think.
Right. Well, thank you for sharing that. Very useful. Oh, I have a question that came in. So this person would like to ask, she would like to know that if she has 3 failed transfer, both fresh and frozen, does it mean that her lining is not receptive? And if she were to continue with IVF cycle, will the results still be the same? And is the success rates lower with more IVF cycles? Dr. Khan? Dr. Liao, would you like to? Yeah.
So she's had 3 fresh and frozen cycles. She hasn't got pregnant. So what it means that the embryo that was replaced back into the uterus, it didn't implant. So she didn't get pregnant. So when an embryo is put back into the uterus, it doesn't implant. There are 2, just looking at it, there are 2 big reasons for it. One is there's something wrong with the embryo, and the other one is something wrong with the uterus. 70% of the time is something wrong with the embryo, okay? Even as you get older, if you are, you know, more than 37, 40, 42, then maybe up to 90% of the time, there is something wrong with the embryo, okay? When I mean something wrong with the embryo, it means there's something genetically wrong with the embryos. Therefore, it does not implant. So even if you put it into another woman, you put it into a younger woman, it's still not going to work because there's something wrong with the embryos, okay? The problem with saying that is that people will say, then why don't you test the embryo? You know, and if you test the embryos, then you would know. But it's not so simple. Even with, Dr. Liao didn't mention about this thing called pre-implantation genetic testing. Even if you tested that, that's only going to be testing a very small part of the genetic issues. So we're going to be testing for carrier type. So we know it's 46XX, 46XY. But a lot, you know, probably more than 80, 90% of the time, the genetic testing, first of all, we can't test. Second of all, we don't know what to test. So something wrong with the embryos. But it's not that something wrong with the embryo is the same problem with each cycle. So it's not, I mean, it may be, but it's not, most of the time, it's not like that. So this man, this woman, they come together, the sperm and the egg, and then they create these embryos that are abnormal, and the abnormality may differ from cycle to cycle, except that in this particular case, they have a higher percentage of creating abnormal embryos than the next person, and that's why it hasn't got pregnant. But going forward, there is not a lot of things you can do about that, except unless you're willing to change either the sperm or the gamete, you know, almost like do an experiment to see whether one or the other is causing the issue, or you just keep trying. Because although we said, yes, there is a higher chance of this couple making abnormal embryos and therefore they're not implanting, there's also the possibility that, you know, this couple has just been unlucky, and if they do enough cycles, eventually you will get a normal embryo to implant. And just to finish off, the 30% of the time where it is a uterine problem, we're not only talking about anatomically something wrong with the embryo, the uterus. So we're not talking about polyps, fibroids that will decrease the chance of getting pregnant, and those need to be sorted out, and those are quite easy to be investigated and found out. We're also talking about more subtle things like, you know, is there any autoimmune, any immunological factors, any antibodies, natural killer cells that is preventing So basically targeting the embryos and not allowing the embryos to implant. And this field is still, we're still at the beginning. And even though there are tests to do that, we're not quite sure whether these tests really test what we want to know, and whether that, which is, does the woman have certain antibodies that is preventing the embryos from implanting? Don't forget that the embryo is not completely immunologically the same as the woman. It actually contains a foreign body, which is her partner, which is her husband.
Okay, let me add on this one. Sorry, Dr. Khan, are you done with that?
Yeah, I finished.
Yeah, Dr. Khan was mentioning about the quality of the embryo. Yes, one of the factors that affect implantation, of course, is the quality of the embryo. And of course, and as I mentioned in my slides here, I see more and more men having issues with the sperm quality, not in terms of sperm count or morphology, but more in terms of the DNA quality of the sperm. So you may come, the men will have a good morphology and whatever. If the sperm are not identified with the DNA damage and it creates an embryo, then of course the quality of embryo will be affected, and that could be also affect the outcome. And then another thing also, there are other factors involved. So how the quality of the embryo can be improved, then it all depends on because I'm the laboratory side, so it all depends on how the eggs are handled from the beginning, right from the egg retrieval, how the embryos are being handled, and how the embryos are being handled during the transfer. So all these factors, laboratory factors, can also affect the chance of getting a good outcome. So you can have a good embryo, but if the things are not handled properly, that will affect the quality of the embryo, and then implantation will happen. Thank you.
Dr. Khan and Dr. Liao for your answers. Now, speaking about embryos, actually, what are the options for embryos that won't be used?
What are the options of?
For embryos that won't be used.
Oh, okay. You're talking about, let's say, if the couple have some excess embryos that have been frozen, and then let's say they have completed the family size, let's say, right? Some remaining in storage, all those things like that. So what the couple can do is to give consent, because the laboratory cannot just discard them or whatever. We still need the consent from both the husband and the wife to give consent what to do with the extra embryos. So one of the consents would be either they donate it to anonymously to another couple, or give allow us to dispose all the embryos, or donate for research work. So usually when the couples come to Virtus, we will give them the consent form, or usually at the end of it, let's say they say they want to come in, they don't want, then we'll give them the options, what they want to do with them. And as for those embryos that could not reach the blastocyst or have arrested development, up to 2 days or 3 days old, and then they stop growing and cannot reach the blastocyst stage, those embryos will be discarded and will not be used anyway. They'll just discarded into a biohazard bin.
All right, thank you for the answer, Dr. Liao. Now, I see that Farah has sent a question in the chat. She would like to know how to detect hydrosalpinx. I'm not sure if I pronounced it correctly, but yes, and she would like to know what is the impact of it to embryo transfer and what the treatment can be done. Dr. Khan or Dr. Liao?
So hydrosalpinx, salpinx is the Latin word for the fallopian tube. So hydro is water, so that means fluid in the fallopian tube. That's hydrosalpinx. So normally the fallopian tube is nice and slender, but when it gets infected or inflamed, it will bulge up in certain sections of it. It bulges out, and then water fluid from the secretions in the glands inside the lining of the uterus will gather up there, and that will be a hydrosalpinx. If that fluid is usually sterile, but if it gets infected, then that fluid will become pus, and then it's called pyosalpinx, which is But then the patient would know by then because it would be very painful, whereas a hydrosalpinx may not be noted by the patient. The definitive way to diagnose it is a laparoscopy. So you put the patient to sleep, put a scope, laparoscope into the belly button, through the belly button, and then you have a look, and then you can see the hydrosalpinx there. Okay. Another way of doing it is doing ultrasound, usually a transvaginal ultrasound, and you can see that instead of the fine little tube, you can actually see a bulge in the fallopian tube. Unfortunately, that bulge full of fluid, sometimes the fluid drains out, and then you wouldn't be able to pick it up on ultrasound. But when you do a laparoscopy, you can see, because clearly that part of the fallopian tube is damaged. Implications for IVF is that, remember that we're going to be putting embryos back into the uterus, and then the embryo has about, because we transfer the blastocyst stage, usually about 24 hours that embryo has to implant. That fluid in that fallopian tube, if at that time it decides it wants to flush out, and there is a patency, there is patent between the uterine cavity and the fallopian tube, then that fluid will flush through the uterine cavity and flush the embryos out. So it will decrease the chance of the embryos implanting. So that's one theory. We know for sure that if you have a hydrosalpinx, your chances of getting pregnant through IVF is decreased. It's not nil, but it's definitely decreased. And there's many studies have shown that. The other way they think, besides the flushing theory, is that there are toxic substances within that fluid, or especially it becomes pus, that will also affect the uterine cavity and therefore implantation. So even if the fallopian tube was blocked, that means there is there's no way for the fluid to go into the uterine cavity because she's got already a blocked fallopian tube. So the flushing theory doesn't really work, but because of the toxic substance, they think it also will affect. So how to deal with it? Very easy. If the woman can accept it, is to take out the tubes, take out the fallopian tube with the hydrosalpinx. And usually if you're going in, because if it was infected, infection doesn't just affect one tube, but that tube is more affected, it will have the hydrosalpinx. Usually it will also affect the other side. So normally we would take out both tubes. But like I said, if the woman would accept, because if you take out both fallopian tubes, then this woman has no chance of getting pregnant naturally. She will have to do IVF. Okay. The other way to do it, which is not as good, is if the woman doesn't accept that she wants to take out the fallopian tube, is to clip it. To clip the at the point between the fallopian tube and the uterus. It's like a sterilization procedure. So this will, in theory, stop the flushing theory of flushing the embryos out, but it still will not stop the toxic substance from affecting. So we know that even if you clip it, your chances improve, but still not as good as if you took out the tubes. Does that answer your question? Sorry.
Yes. Yep.
No answer.
I hope it answered Farah's question. Yes, I have another question. Can a couple that is above 45 years old try for IVF? Dr. Khan, would you like to?
There's no, as far as I know, there is no law against 45-year-old women trying, as long as there are eggs in the ovaries. So we would do, we will take a history to make sure that she's at least having periods. Then we would do an AMH level to see that yes, there are eggs in the ovary, that we stand a chance that when we stimulate, we can produce eggs. Okay, but there is no doubt, and I think Dr. Liao is going to reiterate that the quality of the eggs that we get, first of all, the quantity is going to be less. Unlikely that we will get 10, 1 to 5, we're happy already. And then the quality, so even if you get 10 eggs, the quality of a 45-year-old woman's egg compared to a 35-year-old woman is so great that the pregnancy rates reflect that, it just goes down as you get older and older. The oldest woman that has got pregnant using her own eggs that is recorded in IVF is about 48, okay? So you hear a lot of people that get pregnant at 51, 52. I think the oldest woman ever getting pregnant is 63, Italian woman, also an Indian woman. But those are not using her own eggs. Those are egg donation. So if you hear of any actress or singers that get pregnant at 48, think egg donation. They won't tell you this, but think egg donation.
May I add? Now, before 2020, in Singapore, there is a regulation that limits the age of the woman going for IVF. So as before 2020, when a woman reaches her birthday of 45 years old, then she has to appeal through the doctor to the ministry to at least get 1 or 2 IVF cycles done. Yeah, so the MOH will review the case by case basis. But since 2020, the Ministry of Health has removed the limit of 45 years old. So now women who are 45, even 50 or 60 years old can go for IVF, but of course with conditions. So those women who are 45 intend to start IVF, they have to go for a medical checkup. All right, so looking at the health status, the ECG, and then the blood test and everything, and certified by the doctor before the IVF cycle is done. Yeah, treatment is started. Yeah, and also we are seeing, yes, and like Dr. Khan says, the quality of the eggs for women who are above 45 even will not be as good, and in fact the outcome, the pregnancy outcome and the live birth will be less than 10%. Yeah, it could be 5% chance of live birth or less. Yeah.
Thank you, Dr. Khan and Dr. Liao, for answering this question. Speaking about eggs, if I have many eggs, right, how many eggs will you try to retrieve? Dr. Khan, would you be able to answer this?
Yeah, so the terms you have to be very careful. You said the word eggs, but when we do blood tests and ultrasound, let's say we start injections. I show you that slide where we start injections. After about 5 days, we do some blood tests. After a few more days, we do an ultrasound. The blood test and ultrasound gives us an indication of whether there will be eggs. So if there are eggs, usually the estrogen levels go up. If there are eggs, usually when we do the ultrasound, we see a follicle, but we never see any eggs. The only time we see an egg is when we do it at egg collection, where we put a needle through the vagina and we suck out all the follicular fluid. And then the scientist is in the operating theater with us, and he or she looks under the microscope, and that is the first time they will see whether there is an egg or not. So in answer to your question, the question should be, if I have many follicles, how many will I, rather than if I have many eggs, because we will try and suck out all the follicles. If I see 10 follicles, I'm going to suck out 10 follicles. I'm not going to leave any follicles around. I'm just going to suck out whether it is, whether there's an egg or there's no egg. But not all follicles have egg. I would say probably 80 to 90% of follicles have eggs, but there are certain conditions where they are empty follicles. And you go through 5 follicles and there's no eggs at all. Okay, so majority of the time, yes, 80 to 90% of follicles that we see on ultrasound, if it's backed up by the high estrogen levels, we are going to get eggs, and we will suck out all the eggs. All the eggs will go to Dr. Liao, and then he, using the microscope, will then tell us which of the eggs are mature and which of the eggs are suitable for injections and which are, he thinks, of not so good quality.
Right, thank you, Dr. Khan. Yes, you can call us, WhatsApp us, and also email us at enquiries@fertilitycenter.com.sg. And please also follow us on our Facebook and Instagram to get the latest updates of our next webinar and sharing sessions. Okay. Once again, thank you so much for having spent your lovely Saturday afternoon with us, and do take care, and we'll see you next time. Thank you. Bye-bye.
Thank you.
Thank you, everyone.
Bye.